Good afternoon. Welcome. Bienvenidos. For those of you who want to continue in English, please stay put.
Las personas que desean escuchar la versión en español, por favor, elegir el idioma oprimiendo el botón en forma de círculo donde dice español en la parte inferior de la pantalla. Gracias.
Thank you, Tiffany. And again, welcome and good afternoon to all of our live attendees today. We are thrilled you are all here to engage in this exciting webinar, Financing Equity and Justice to Address the Behavioral Health Needs of Our Youth in California. I am Molly Streer, and I am one of the hosts of our webinar today. My pronouns are she, her, and I am a white, cisgender female in my early 40s with dark brown hair that is pulled back. I am wearing a black top and my background is blurry. I'd like to acknowledge that SF State's campuses in San Francisco sit on the ancestral homeland of the Ramaytush Ohlone. We further acknowledge that we work on the ancestral lands and waters of many other Indigenous peoples and nations in our field work in the Bay Area and around the world. We are committed to ensuring this webinar is accessible to our audiences. Closed captioning is available in the closed captioning option at the bottom of your Zoom screen. If at any time your access needs are not met or become not met during the webinar, please send a chat directly to a host or co-host. A reminder to all our speakers, please speak slowly for our interpreters. Access is always a work in progress, so we appreciate your comments, feedback, and support. I am a faculty member in the Department of Counseling in the School Counseling Specialization here at San Francisco State, and I am one of the co-investigators of this project. I am working alongside the project's primary investigator, Dr. Julie Chronister, who is faculty and coordinator of our clinical mental health counseling program, and my co-investigator, Dr. Tiffany O'Shaughnessy, who is faculty and coordinator of our marriage and family therapy program. I would also like to thank our graduate assistants, Christina Cabiles, Ro Cordova, and Shunui Igwe, who are both working hard, all three working hard to stay on top of the technical issues, chat boxes, etc. today. This is our 6th of 10 webinars sponsored by our Equity and Justice focused integrated behavioral health counselor training projects, which is fully funded by the Department of Health and Human Services, Health Resources and Services Administration as part of an award totaling $1.9 million. A couple of additional things before we begin. If you are one of our HRSA stipend recipients or are interested in receiving continuing education units for your attendance today, please pay close attention to the announcements provided in the chat for sign-in and evaluation links. As a reminder, this is a live recorded Zoom webinar. Therefore, the audience is not visible and the audience cannot turn on their video or audio. The chat function is available for comments, sharing of resources, supportive emojis, etc. To ask the presenter a specific question, please post your question in the Q&A function. Q&A will occur during the last 10 to 15 minutes of the webinar. So please post your questions in Q&A as your questions emerge, and the presenter will answer questions at the end of the webinar. If we cannot get to all of your questions, please contact the presenter directly. The presenter's information is posted in the chat. It is with great pleasure that I introduce today's presenter, Alex Briscoe. Alex Briscoe is the principal of the California Children's Trust, which is a statewide initiative leveraging behavioral health supports, strategies, and resources to achieve healthy development and health equity for children in California. In this role, Alex is redesigning behavioral health services in child-serving systems, improving access and accountability. From 2009 to 2016, Alex was the director of the Alameda County Health Care Services Agency, where he developed programs to address the social determinants of health while implementing delivery system reforms, expanding access to primary and preventative care, and redesigning the emergency medical system. As an administrator, practitioner, and leader, Alex has held several other positions contributing to the behavioral health and educational needs of youth, as well as serving on many boards and commissions focused on health equity. Through Alex's work on the intersection of public health and public education, he is truly an expert on navigating integrated systems of care that promote equity and access for youth. Thank you for joining us today, Alex, and it is our pleasure to have you here. Please take it away.
Thank you to Molly and Julie and everyone who is here today. I also would really like to acknowledge the interpreters today, because we're about to dive down some language that's going to be difficult to hold and translate. So thank you so much for your support. I think before I begin, I need to remember a really important piece of guidance I got from a mentor of mine who once said to me, "We have the most complicated descriptions for the things we understand the least." And I think it's fair to say that we understand very little about how to mitigate the impact of 400 years of structural inequality and poverty on the social and emotional health of children. As I'll talk about in a second, we know that's what's driving what's happening, but we really don't understand how to effectively mitigate it. And so the system that I will try to unpack for you and explain to you today is, I think, reflective of that lack of understanding. I will also just say to everyone listening today that I hope if you take nothing else from what I'm going to say today, if I spontaneously combust in the next 30 seconds, I would hope you would hold two things. The first is that mental health is not a response to pathology. It's a support for healthy development in an increasingly toxic culture. And the second is, for young people or folks just entering the field, know how the money works. Essential to systems change is changing the flow of dollars, because that really is what moves systems, is power. And just and equitable systems change involves the shifting of agency and power. Agency as defined by who does it, power as defined by who gets paid to do it. So let's break the medical model and understand how stuff gets paid for. That's what two things I hope you take from what I'm about to say today. Sorry, having a little slow here. So what I'm going to do is give you some data that you probably know. If you are a kid or were ever a kid or have a kid, you know that something's going on with kids. So I'm going to give you the data. You probably have seen some of it, but I'm going to try to go through it quick. And then I'm going to explain why Medi-Cal is so important. Medi-Cal is California's version of Medicaid. So I don't mean to talk down to anybody, and I know there's a wide variety of folks on the call today, but I'm actually going to unpack for you what Medicaid and Medi-Cal are and why they're so important, not only to children's social and emotional welfare, but how we fund and administer systems. I'm going to actually ask you, like the therapist I was, to see some of our challenges as opportunity. And that's really what the Medicaid program and context is. And I'm going to show you how the money flows, where it starts, where it goes, and how it lands. And then talk about how to change it, like how to think about a future state, how to talk about the future like we've been there, and then talk about some of the reforms that are happening, because stuff is really moving. A lot of promises have been made, both in terms of unprecedented commitment of resources, but also in some fundamental shifts to how things get defined and how young people become eligible. And then we'll talk for as long as you guys want. Thanks. So first, there's actually an emerging consensus that something's happening. Like there is a new administration at the state level, led by extraordinary people that are doing stuff for kids and young people's mental health at levels we've never seen. And, frankly, it's past time. Californians have said for years in the California Healthcare Foundation surveys that mental health and children's mental health in particular is a major concern. And there's an emerging consensus and consciousness that it's not the kids, that it's something about what's going on, as I'll show you in a second, about what's happening with young people. There's some things that are happening, and it's not like all of a sudden young people got pathological, though twice as many young people are hurting themselves as just 20 years ago. So we didn't spike the water. It's something actually about us as a culture that's making it difficult to be a young person. And when you look at our culture, you have to acknowledge the impact of race and class, or you're not really talking about our culture. But to take advantage of this confluence, this thing that's happening, we have to reform how we do and pay, but also deepen partnership that reimagine mental health, not as a response to pathology, not as a medical model intervention, not as an empowered professional class serving a disempowered, impacted class. Like, we have to shift. And that means shift how we define and pay for stuff. And I'll get into the details of that. I know that's a flowery beginning, but stick with me, because what I'm about to try to show you is how these ideas become real and how California supports the social and emotional health of children. For those of you who bill Medicaid or worked in Medicaid, it must be hard for you to hear me suggesting that Medicaid may be one of the greatest opportunities we have. If you've ever tried to bill it, as I have, and it probably is an important time for me to reference this truth. I started my career as a therapist in West Oakland at McClymonds High School, where I worked for 7 years, starting a clinic and working with a lot of extraordinary young people. I then worked at a level 1 pediatric trauma center, Children's Hospital and Research Center at Oakland. And then I designed and led a number of programs for the county in juvenile justice and foster care and emergency medical services. I say all of that to reflect on the fact that I have seen a lot of human suffering. I can name all 27 young people who died in my care. But the truth of that experience of 25 years of working with young people isn't the challenges they face. It's the beauty, the wisdom and intelligence that so many showed, that so many thrived and survived despite, is what I've taken away. And I think if we reimagine the beauty and wisdom and intelligence of young people, that path will be clear about how to support them better. But that means rethinking how we fund and deliver. All child-serving systems in California, all of them work the same way, actually. They distill to the same administrative structure. They all have some federal laws that are tied to some state actions, but every child-serving system in California is administered at the county or regional level. That's true of all child welfare departments. They're run by county child welfare departments, 58 of them. That's true of juvenile justice departments that are run by county probation departments. It's true of all of the early childhood programs. Hard to call those a system, but First Fives are county run. It's true of all of our local educational agencies. LEAs is what we call school districts and county offices of ed. And it's also true of our regional centers, where disorders of development, autism, and mental retardation are all supported in a separate reimbursement and delivery system. So these are what you might call the big five of the child-serving safety net. But they have a common denominator. They all have an essential element focused on the social and emotional welfare of children. In fact, financing from Medicaid is interwoven into all of these systems. Medicaid pays for a lot of stuff in special ed. Almost half of all kids in child welfare get a unit of service. The regional center is itself a Medicaid program, although separated out and distinct. So what I'd like to suggest today is that we all think about Medicaid not as a separate bucket, but as something that can be a platform, if reimagined, if infused with the principles of anti-racism and social justice. It could be a way to reform a very troubled child-serving safety net. And why? Well, I present these numbers all the time, And I vacillate between not wanting to show them because I think they dehumanize and diminish the human suffering behind them. But let me just name them because it's important that that everyone understands that we were in a legitimate crisis before the pandemic. And the pandemic did whatever you call pouring a bunch of gasoline on a crisis and lighting it on fire. That's what we did. But it's really important to acknowledge that the pandemic didn't create the youth mental health crisis. It existed well before. And that crisis is unique to America. When you look at what costs our healthcare system, mental health and behavioral health, drug and alcohol and mental health together, are the leading disease burden in America. I mean, they cost us more when you measure something called daily adjusted life years. This is a fancy term for how many days you spend in the hospital and how many days people are on disability. So a very crude and rough metric. But what's important to note is this is unique to America. Not only is it the most expensive thing, but it only happens in America at this level. So this is the beginning of the story I'm trying to explain, that it's us. It's not young people. And as long as we continue to pathologize young people, diagnose them, we are obscuring the true drivers of the youth mental health crisis. And to dig into the actual data, in the decade 2007 to 2017, we saw a 104% increase for hospital admissions for self-injury, a 50% increase in pediatric mental health days, a 61% increase in self-reported mental health needs. Young people were telling us through the California Healthy Kids Survey that it was a tough time to be a kid, but we weren't listening. And California, this is one metric, I'll show you a bunch of others. I think the clinical term is we suck. Our progressive politics and public narrative crash on the rocks of what actually happens for poor kids in this state. Yeah, sorry. Sometimes I want to pause on these numbers because I feel like they can, as I mentioned, diminish or demean the suffering behind them. This is a socially constructed epidemic of despair we are trying to address. And if we continue to pathologize young people in order to generally pay for the salaries of a largely white professional class, we're contributing to the harm that we're trying to address. If you don't disaggregate this data by race, you're missing the point. As I'll explain in a second, more than half of all kids in the state are on Medicaid, what we call Medi-Cal. 80% of them are non-white. The suicide rate for Black kids is twice that of white kids. I could go on. This data is reported ad nauseum. And what I'm trying to suggest here is making healing-centered schools or communities isn't just about tweaking the technocracy. It's about reimagining what we mean by mental health. Sucking it out of the medical model. What I would say colloquially to all of us is we need the healthcare system's money, but we must reject the medical model. And for those who want the data, and these slides, of course, are yours, and I will suggest some of us don't even believe in intellectual property and social justice endeavors, so anything you can see here, you are welcome to cut and paste and use. If you want the citations, they're all available on our website. This data has now been well reported. Yes, the pandemic and isolation really did impact the social and emotional welfare of children. And we're no longer arguing if your context impacts your social and emotional welfare, right? Like, when I do this talk for broader stakeholders, the first 50 emails I get are from privileged people whose kids are in the hospital on the wrong meds or don't have anything to discharge them to. So when you combine the pre-pandemic data and the impact of the pandemic, you have, as I mentioned, whatever you call a crisis that you poured a bunch of gasoline on and lit it up on fire. We could spend the rest of today and tomorrow talking about what's driving this. Is it 400 years of structural inequality? Is it social media becoming available on mobile platforms in 2009? Is it a broader culture that equates fame with merit and wealth with value? And I would say the answer is yes, it's all that stuff. But as long as we remove the locus of power from the actual pathology of children, then we're talking about the right stuff. And school success is driven by mental health challenges. It's the leading cause of dropout for any disability group. And as you probably know, almost half of all lifetime mental illness begins before the age of 14, but the average delay of onset of intervention is 10 years. I think it's fair to call the existing children's mental health system to describe it this way. Most kids get nothing, and those who do get the wrong kind too late. I think that's a fair characterization of the system that I have been either working in or administering for the last 20 years. So how did we get here? And again, this is some background information about like, why is it so hard? And it's so hard because the medical model won't work because it's culturally bound and racist. But it's also a plumbing issue. Kids 10 to 24 use the healthcare system the least. So right when you need, even if you wanted to apply the medical model, you couldn't because the plumbing doesn't work. We don't have enough practitioners. Even if you wanted to give every kid a 50-minute session, which they don't need or they don't want, you couldn't because they don't exist. And diagnosis-driven models are only appropriate for some young people. And so when I do this talk, sometimes I get this feedback of, oh, you don't believe mental health exists? Of course not. Like, I have literally served thousands of families and children. And what I would say is about 15, 20% of them definitely needed the narrative and cognitive behavioral therapy that I was trained in. I've seen medication transform and improve young people's lives. So I'm not suggesting that mental illness doesn't exist. But the vast majority of young people who are hurting themselves, who are driving the youth mental health crisis, are not pathological. They are not mentally ill. They are dealing with really tough stuff in their lives. And that's what makes this moment so unique, is through a combination of an emerging consciousness, Dr. Nadine Burke-Harris's extraordinary leadership, we are now beginning to say, what is driving this? And maybe it's more about adversity and structural racism than it is about the individual pathology of children. Our systems are fragmented, and I'll just drop down to the very bottom on the right-hand side of this slide, is what I also like to suggest is if you take a breath out and summon the generosity of spirit, we're literally in the first 20 years of the mental health system's implementation, because the models we're using are less than 20 years old: cognitive behavioral therapy, narrative therapy. The first 20 years of heart surgery was pretty ugly too. So the field is young and we're learning. So I'd like to think that if we can bring the principles of social justice in, there's a chance that we can transform the system, because one of the great promises is that there's not a big system to kick out of the way. Like, that's the great opportunity before us, is we can write the rules in ways that we couldn't if we were dealing with physical health. I'll pause for a second. Again, I want to thank the translators so much for trying to track me and this language. This is really tough stuff, and I'm about to make it harder. So thank you. The same mentor once told me that we are all better when we act on the exhale. So I'm going to breathe out before I dive into some technical stuff to try to explain California's MEDICAID program. California's MEDICAID program is a $105 billion behemoth. It's the largest Medicaid program in the nation. Remember, Medicaid is the federal definition. MEDICAID is California's version of Medicaid. And remember how I showed you that behavioral health is the leading cost driver of our healthcare system? Like the number one disease burden? But of that $105 billion, we only spend 9% on behavioral health. MEDICAID covers a third of all Californians. But when you think about kids, it's much bigger. Almost 6 million children are now, of the 10 million children in California, are now covered by Medicaid. And very few are accessing anything at all. In fact, 96% are eligible but not accessing services. And when you think about why this is such a travesty, is think about kids for a second. Like, they're healthy. You can kick them, they'll make it to 18. What kills kids? Literally, what are the 3 leading causes of death of children? Homicide, suicide, injury, car wrecks. None of them are physical health disorders. Cancer is number 4. If you're going to address what's killing children, you have to address the decision-making and their context. They have to be taught how to manage the messaging of a culture that actually doesn't care about them and may be actually directly harming them. And I will say, having started a number of peer mental health programs in schools, I've always been fascinated by the narrative around the LGBTQ community for children. We often point to the disproportionate rates of self-injury and the challenges that LGBTQ kids face. What we don't talk about enough is their overrepresentation in social justice and community organizing work in high schools. LGBTQ young people are overrepresented in the peer-to-peer mental health landscape because they've had an experience of rejecting a social norm, and that struggle puts them in a unique position to help other young people understand the impact of race and class. Of California's 10 million kids, I mentioned this is about a 30% increase over the last 5 years. There's lots of policy background on that. I can talk about SCHIP and Medicaid if you want, but really one way to think about it is California is ground zero for income inequality. 7 out of 10 children will be born into poverty, will never get out. So this kind of American myth that, like, hey, it's on you, big fella, you do it, you're going to come out. That's not true. And I think part of what's driving this crisis is that young people know it. If you're a young person and you look up at the world, you don't see people who look like you making decisions. And I think young people increasingly know that the system is rigged. So while eligibility has increased, right, that 30% increase, less than 5% of those 5.5, almost 6 million kids now get access to any care at all. So I mean, touch the system, touch it at all. That means just one call into the Medicaid system, one unit of service. Less than 3% are in ongoing care, and many of those are juvenile justice and child welfare involved kids. So they're getting it in highly restrictive settings, not from people who look like them, not from people who love them and are celebrating their wisdom and intelligence, but often from systems that are trying to control and manage. So stick with me. I know this is depressing, you guys, because I'm going to flip the solution, but stick with me a little bit more because Medicaid is challenged, but I'll explain why it's our greatest hope as well. California ranks in the bottom third nationally in spending per kid. So if you may or may not know, but we tax ourselves as a state among the highest levels, but we spend among the least. So I'll explain why that's an opportunity in 1 second. Kids are 42% of all enrollees in Medi-Cal, but only 14% of expenditures. We're 44th in the nation in access to needed mental health services. More than this study in 2019 shows how much I think the technical term or the clinical term I mentioned was we suck. So it's hard, again, to see this challenge program as a solution. But let's talk about what the solutions are. One is that we now are understanding why schools are so important. The healthcare system needs schools. Those utilization and access patterns I talked about mean that kids don't go to the doctor, but they do go to school. Schools make great places to do this work. In a future state, schools have to be legitimated as essential network providers in healthcare systems. Schools aren't a handout to the healthcare system, they're a hand up. It's like a peanut butter and chocolate moment. Like together, we can help address the youth mental health crisis if we stop trying to send kids to therapy offices and start doing stuff in schools and communities. And now to flip to hopefulness, the finances align. So here's where I said, remember that I'm encouraging everyone listening today to focus on the wisdom and intelligence of young people, but also on the money. So let's talk about the money and why there's such important opportunity right now. Medicaid, known as Medi-Cal in California, is complex, but the financial architecture of it is really straightforward. Every Medi-Cal expenditure has two parts, a federal part and a state part. One way to think of Medicaid is like it's a pot of gold sitting in Washington, D.C. You get $1 if you put up $1. Every Medicaid expenditure has this bifurcated structure, a state dollar and a federal dollar. That state dollar has a fancy name. It's called a certified public expenditure. And you could distill my entire career to looking for those dollars to match. So if you're in Medicaid world, you're always looking for a public dollar that's eligible for a match that isn't getting it. That match is called federal financial participation. So it seems pretty simple, right? If we tax ourselves at this really high level in California, third most in the nation, how can we get the 39th most federal matching funds? And that's the opportunity that I'm suggesting we play in. That there's a huge opportunity in California to bring in new money if we can restructure our Medicaid program. Well, so let's talk about why it sucks if the opportunity is there. How come we're not getting that match? Well, that federal dollar, that bucket in DC, goes to the state. How does it show up for kids? Well, the biggest payer are the managed care plans. Every county has a different economy of Medi-Cal managed care. In San Francisco, you're in a 2-plan county, the public plan, San Francisco Health Plan, the private plan, Anthem. Some counties have just one public plan. Those are called county organized health systems. Other counties are competitive. Medi-Cal managed care matters a lot. In 1995, about 10 to 15% of kids were in a health plan. Now 90% of kids are in a health plan. So it's really important to understand the role of Medi-Cal managed care. The next way those dollars flow down to children and families is through the county mental health plans. This is sometimes called a carve-out. And the county mental health plans are actually a health plan too. And until 2015, the only way to get a mental health service was through your county mental health plan. But now there's two payers, both the Medi-Cal managed care and the county mental health plan. Those are the two biggest ones. But schools can also bill directly. So can community health centers, what we call federally qualified health centers. So can public health departments. So can public hospitals. And so can the regional center. When everyone is responsible, nobody is. And one of the reasons we are so stuck in California is we have diffused accountability for the social and emotional welfare of children across such a diverse landscape. And what happens is these systems all point at each other. Like if you've done the work I've done, you are often in a conference room talking about brown and black kids with mostly white people, pointing at the other people in the room saying, no, you should pay. That it's not my kid challenge has to be addressed. Here's in blue are the ones that are most important for schools, just to tie it back to the school stuff, how schools are essential to any response at scale. So let's talk about what's next and how to make this thing work and like why what's happening now is really important. And some really, really big things have happened. Not only, I'll explain for you in a second how we're about to spend $15 billion on children in the next 5 years, but also how we've done some things that will make it attempt to break the medical model. So the policy wins have just been achieved, but it's now up to all of us to disseminate them and break current practice and expand it on new principles. So there is hope. There are new and emerging practices. Like people are doing really interesting, fun stuff, and the systems are starting to pay for it. And it's past time. I'm about to do something that I'm sure Molly and Julie and many other people on this call could take big issue with. I'm going to try to distill for you the history of psychotherapy in one slide. And it's way wrong, but it's an attempt to eat the universe, so stick with me. And for those of you who are watching, you should definitely note that almost every name in the first 4 waves I'm about to show you is a white man. But if you go back to the origins of psychotherapy in the sort of psychoanalysis, skip the Catholic Church and begin with the psychoanalysis phrase, we might call that the first wave. Wave 2 might be considered like a behavior modification, Skinner, Watson, sort of early 1900s. Wave 3 might be the sort of really interesting and fascinating work of Erik Erikson and Frankl and others. You might call the wave we're in right now being the cognitive psychotherapy of CBT and the addition of mindfulness to DBT. Like I would say these are kind of a very rough attempt to describe the history and the evolution of psychotherapy. But what's happening now, and maybe what's most exciting, is we are starting to talk in new ways about the centering racial justice and healing as a mental health support and changing delivery models, not only location from therapist office to schools, but also changing delivery models by removing diagnosis as a prerequisite for care. Hint, hint, nudge, nudge. That's the biggest policy win we've had in the last year. Is both of the 2 big payment systems have formally, as of December 29th, removed diagnosis as a prerequisite for care. It's a really critical first step in stopping the pathologizing of brown and black communities. But these other modalities are now becoming more and more acceptable and reimbursable. We're expanding the eligible provider classes. We're adding doulas. We're adding community health outreach workers. We're adding behavioral health coaches in schools, and we've added peers through SB 803. Those are the 4 new provider classes just recently approved by California's MEDICAID program. And I won't go through the rest of it, but there is real change happening. SF State and others are at the front lines of it, but we are thinking about new ways to do mental health. And to me, it's a crisis that can be leveraged to break past practice and do something more just and equitable. The data on mental health is really clear. It actually works if you treat people. Like you can stop young people who are schizoaffected from becoming schizophrenic with the appropriate level of treatment and support and medication, let alone stop young people from entering the prison industrial complex. So there's all sorts of amazing data out there. Like when I hear sometimes, well, we don't have any data on whether mental health works or not. I don't even know why people say that to me anymore. It's infuriating. Anyway, there's lots of data. This is just a small subset of important efficacy double-blind style studies. So I do want to be hopeful because not only am I a hope addict by nature, but I also believe things are changing. Something is happening because we're all worried about our kids. And boy, is it past time. Our culture needs to heal. And one place that we may have demonstrated, however paternalistic and challenging our past efforts have been, no one steps over a crying baby. Like, can we as a culture set aside our differences to address the fact that twice as many of our children are trying to kill themselves? I think there's I talk to all sorts of different people about this issue from different walks of life, different political persuasions, and Everyone is worried about their kids. So I'd like to think this is a place through which we can have conversations that may be more difficult to have in other settings. This is that 15 billion plus that I talked about. Basically, everyone is so freaked out that they're throwing money at the problem. Now, it certainly helps that money is literally falling out of rich people's pockets right now, meaning the revenues that drive the public sector at the state and local level are like vehicle license fees and sales tax and a millionaire's tax. That's Prop 63. So there's a lot of money. Now, it's being thrown out there without addressing some of the fundamental challenges of that fragmentation I talked about. But it's better to have money to spend than not. And here's just some quick things. So those of us at the Trust have been working very hard on the recently announced $4.4 billion Youth Behavioral Health Initiative that removes diagnosis as a prerequisite for care across all payment systems, that generates a bunch of money for schools to build mental health programs and supports in schools. Lots more on this. The governor's budget throws in almost $4 billion to expand after-school programs with a health and wellness focus. The Community Schools Partnership Program, which basically the first pillar of the 4 pillars of the community schools is integrated services and supports. And then there's obviously the federal stimulus money. What I would say to those of us who are have worked in public sectors, one-time money is actually problematic. So when you see these dollars, like even someone like me saying, "Oh, look at all this money being spent," I hope you raise an eyebrow and be like, how much of this stuff is ongoing and how much of this is just people freaked out about kids? Because disentangling what's ongoing from what's one time is a really important level of critique that you should apply to slides like this or people like me who are talking. And unfortunately, about $1.5 billion of this is ongoing annually. So it looks bigger than it is. Now, if you'd asked me 3 years ago when we started the Trust, if I would accept a multi-billion-dollar ongoing investment, I would have been ecstatic. But now we think it's nowhere near enough. These are the details of the Youth Behavioral Health Initiative. If you go to the California Children's Trust website, you will see a deck that breaks down each one of these investments, the timeline. It will raise as many questions as it answers, but it also links to the trailer bill language. So for anybody who wants to go into it and see what these things are, you'll see a theme. The theme is schools. The theme is early childhood behavioral health tied to the caregiver, meaning poor people on Medicaid interact with the healthcare system the most frequently in the first 3 years of their child's life when they take their baby to their well child visits. But the way Medicaid works, you have to have a diagnosis and identified patient. So you could, who's going to diagnose a kid who can't talk? And when mama brings the baby in, who do you bill on? And so we created a new benefit called the dyadic benefit that the state approved. That's number 5 here. And so we should be entering a golden age of integrated behavioral health in pediatric primary care and family practice. So the 2 themes to take from this slide, besides the one-time grant money, is that schools are centered and pediatric primary care. Both schools and pediatric primary care get big new sustainable investments long-term. And then I would also point to the workforce stuff, meaning the idea that we need to build a healthcare system for people by people, that licensed clinicians are important, and clinically informed support is important, but it doesn't always have to be clinically intermediated, meaning that people, peers, social models, mutual aid, there are lots of community self-rescue. We won't address this by doing 50-minute sessions with young people. Like building social capital and building connection and relationship. We have all been harmed in relationship. We can only be healed in it. So there are real signs of progress. This is what I mentioned. This project that created the dyadic therapy was done at the Children's Health Center in San Francisco. Super important thing to track. It's that idea of like, how do you bill for the caregiver when they bring their baby in? So this paper was called Babies Don't Go to the Doctors by Themselves. It was a demonstration we did in San Francisco with the San Francisco Health Plan and Anthem, and the state picked it up and approved it for statewide adoption. The family therapy benefit is the first time we've had a benefit in Medicaid that allows for billing due to an experience of racial discrimination, housing instability, or any of the 10 adverse child experiences. We all need a t-shirt. That t-shirt says Z65.9. Z65.9 is the new diagnostic code that allows us to say, I am serving a family or a child, not because they have a diagnosis, but because these things happen to them. And that ability for young people to distinguish what happened to them from who they say they are, what we might call adaptive distance from the toxic culture that we live in, That is an essential building block for healing. And the dyadic therapy. So this is the demonstration of the dyadic therapy and the family therapy benefit. So if you wanted to track this stuff, and I do it for a living and it's hard. So just, again, I would invite everyone to breathe out, read. You're not going to get it all at once. Like, it's a messy reform landscape because it's a lot is happening. To me, that's exciting. That smells like systems change to me. But if you're interested in trying to track some of it, I would watch the Community Schools Act. I think this is a really important investment, about $3 billion over 4 years. The schools can now bill Medicaid. Until this year, schools could only bill Medicaid for kids in special ed. Now they can bill for all kids. That was called a state plan amendment, and it's a big win. The Student Services Act is basically the millionaires fund called Prop 63 is worth about $3 billion, but it's going to go to $3.8 billion in 1 year. So think about that for a second. Like 800 million of new money from millionaires is going to flow into the mental health system. So for anyone who's working in a county system, you should be banging on the door of your county mental health plan because they got a whole bunch of money to spend. I mentioned the family therapist and the dyadic benefit, new definitions of what we call medical necessity or the barrier to entry. The after-school programs, CalAIM is the name for all of the reforms that are going on in Medi-Cal, the Behavioral Health Initiative. I didn't mention this, but all those Medi-Cal managed care plans have to rebid their contracts for the first time in 17 years. And a bunch of us are basically waving a flag saying you got to do more and better for kids. So let me end with this slide. And I know I've said a lot, and I'm for the third time going to thank the interpreters in this incredibly difficult challenge of tracking me. So thank you, thank you, thank you. But if you let your eyes soften and put down the burden of all the detail I just told you, like, how would we do this? Like, how can we look at this from a systems level, from the perspective of like, what do we need to do together? How do we organize our approach to this challenge? And I want to acknowledge the work of Dr. Rhea Boyd, who gifted us with this framework. It's her leadership that brought this framework to life. And what we said is, you can't change the system unless you shift agency and power. So the words equity and justice are used so frequently right now that they are starting to lose their meaning. And we at the Trust say what equity and justice means. The essential strategy of equity and justice is the shifting of agency, who does the work, and the shifting of power, who gets paid to do it. So the things like expanded provider classes are really important to just and equitable systems change. You have to spend more money. We can't be in the bottom third nationally giving the non-federal share that we have to match. So spend a lot of money, but do it while shifting agency and power. You have to expand who's eligible, meaning remove diagnosis as a prerequisite for care. Any kid who wants it, any family who wants it should be able to access behavioral health, not because they have a diagnosis, not because they've hurt themselves, but because this is a toxic culture to live in. And we have to acknowledge that in order to address that toxicity, we have to leverage the wisdom and intelligence of young people and their families. And then finally, accountability. When everyone is responsible, nobody is. Clarifying who pays for what and how it's measured is an essential path forward. I'm going to stop. I want to say thank you so much for inviting me to have this conversation, and kudos to SF State for this extraordinary work. Thank you, everybody.
Thank you, Alex. I so appreciate your wisdom and you taking the time to be here with us today. A reminder to our audience, please go ahead and post any questions that you may have in the chat. It was a wonderful talk, and thank you again just so much for sharing. I'll get us started. I like to always interject, unmute myself. Can you all hear me? I have a notice to unmute myself.
They should be able to hear you.
Okay. Pardon me. Sorry. Making sure the technology. Thank you so much. Glad you can hear me. One question I always like to ask is where school counselors play into this landscape. School counselors are typically employed, by the school district. They're very rarely actually doing billing, right? They're more embedded in the school system itself. And I wonder how school counselors specifically can contribute to a more integrated behavioral health model. Alex, what is your experience working with school counselors? How can they connect our youth to the resources that they need?
Yeah, thank you. And I'm now seeing the chat and some requests to go slower, so apologies again. So I'm going to answer that question directly, but I'm going to take one step back, which is, if you were listening, I was saying schools are essential to any solution at scale. So like they're going to be new and important. And lots of money's coming in, but it's kind of like hectic how it's coming in. And schools are really busy and overwhelmed, right? Because they're fighting all kinds of craziness. What I like to suggest to folks who are working in schools is we actually have some agreement on the model for peanut butter and chocolate coming together in schools. And that's got a fancy name. It's called the Multi-Tiered Systems of Supports, MTSS. But sometimes the technical terms like obscure the simplicity of it. It's just a triangle with the kids at the top in special ed, the kids in the middle having unique identified needs, and everybody at the bottom. Like think of it like a population triangle. But these tiers, tier 1, 2, and 3, we have a general acceptance in the school health world about what the model that we're engineering towards looks like. So that's actually really important to acknowledge that. Like we know what to do. The how to do it is the essential building block for MTSS is something called COST, and it stands for Coordination of Service Team. It has different names everywhere, but what it basically means, COST or care team, what it basically means is there a place on your school campus where once a week people come together to talk about individual children and what more you're going to help them get. Those are the two essential elements of COST. It's not about what an asshole the principal is. It's not about all the things you're currently doing. It's about individual children and what more you can get. And what the reason it's so important is schools have been on the front lines of the youth mental health crisis for decades. And they've been responding. I'm coming back to school counselors, so hold with me. They've been responding somehow, some way. And there's a pastor down the street who's giving out backpacks. There's a teacher who keeps their door open after school. There's a mama who's helping young people with no place to sleep find a shelter bed. Like it's happening, but it's not organized. And it's so overwhelming that if you bring people together, you get a stone soup thing that happens. And you structure that conversation and you inform it with the professionals in the school. So MTSS is the model, COST as the essential first step to moving towards the model. The counselors have an essential role to play in constructing COST. Despite the fact that they have master's degrees and that you guys train them in lots of amazing things about the pupil personnel services credential, I think most of us who've worked around schools know that PPS credential folks are doing a lot of admin on getting kids signed up for classes and tracking their credits and all that stuff. And so while many of them are trained appropriately, they don't have the bandwidth to be frontline clinical leaders. So one of the most important things they can do is promote fidelity to MTSS, organize COST, and know the architecture of the system I talked about. Like on the back of every emergency contact card in school, every one is your name, your primary care provider, and your health insurance status. Any of us who've worked in schools know that 80% of those are blank. Those 70% of those kids are enrolled in a managed care plan that's getting money for that kid every month. So for a school counselor, I would say MTSS, organize COST, get the back of the emergency contact card filled out so that you can refer people to the benefits that they currently enjoy.
Thank you. I so appreciate your response. What I'm hearing as a school counselor educator is we should let school counselors do their jobs. So thank you for that, because I couldn't agree with you more. And certainly it's how they're trained, and the ones that I know, it's what they wish they were doing all day long. So thank you so much for that thoughtful response. And also take a moment to read one of the questions that we have received. So with Senate Bill 803, family members and peers are now considered providers. However, the pay for these new members of the treatment team is inequitable. How does one go about advocating for equitable pay for those who have lived experience and may not have advanced degrees?
Oh, I love this question. So whoever asked it, thank you so much. SB 803 is one of the 4 new provider classes I referenced: peer mental health, behavioral health coaches in schools, doulas, and community health outreach workers. Those are the 4 that the state have proposed in terms of expanded scope of practice for mental health. SB 803 is the first one to be done. 51 counties have submitted letters of intent to have an SB 803 program. But there's some real problems with SB 803. The first is it doesn't address this question of rates. The second is counties have to put up that non-federal share. Are you with me? Remember how I said Medicaid's like a pot of gold in DC? So the state approved SB 803, but didn't provide any new money for it. So what it's going to mean is that every county is going to do it different. And because there's no rate structure, the question that was asked of how do you ensure equitable? Well, from my perspective, if you're not paying a living wage, then you shouldn't be reimbursing at that rate. So, I mean, as I would tell my 19-year-old daughter, don't take any job that doesn't pay you 85 grand if you live in San Francisco or the Bay Area. So unfortunately, 803 is the answer to your question is you have to advocate directly at your county mental health plan and your county board of supervisors that they do not pay rates below a living wage as defined by your regional cost of living. The other three provider classes are going to be paid through managed care plans. And that's part of the negotiation that's happening at the state right now, is that the rates that those providers enjoy be tied to local living wage ordinances. And that's sort of the advocacy conversation that's happening. There's a philosophical question that I'll raise. Both CHWs and doulas, part of their power has been that they're extra systemic. Like when Black and brown doulas talk about their work, they talk about protecting marginalized communities from the harms of the healthcare system. How do you buy something without appropriating it? Like, that's an issue I think a lot of us are struggling with. Like, how does the system start bringing in community health outreach workers and let them be community health outreach workers, not people who try to reduce utilization to save cost? So one of the things we've been looking at is like a doula collective in Rhode Island. Like, could you create something where you democratize supervision, meaning a doula can't operate unless they're under the license of somebody? Could they pick their own? And could you create some intermediary where they take payment in on behalf of the doulas, but not on behalf of the health systems, protecting the extra systemic nature of doulas? And I think, so for the other three classes, doulas, CHWs, and behavioral health coaches in schools, we want to make the rate structure tied to a local living wage ordinance paid through the managed care plans. I'm a county guy, but I think the county mental health plans are really struggling. And I think that the future of Medi-Cal reform, whether you like it or not, is going to be run through the managed care plans. I feel like that's an inadequate answer, but for directly and specifically, if you're working on SB 803 in San Francisco, the conversation has to be direct to the Board of Supervisors and the county BHCS, the mental health plan in the county.
All right, thank you. Another question from our participants. Do you foresee school districts, SFUSD in particular, hiring full-time licensed mental health clinicians? The current SFUSD model provides associate clinician and CBO providers, but there seems to be a lack of continuity in school-based therapists who can provide treatment on site and long-term so that they can become integrated into the school culture.
Love it. Great question. Yeah. If you live, so both my children are K through 12 education in SFUSD, and they both speak Spanish, which is beautiful, and I'm so grateful. And it is no surprise to anyone who lives here that the school district and the city have a long-term and troubled relationship. The school district has 100 school social workers that they have not billed Medi-Cal for, that we just started them billing Medi-Cal for. So there should be $1 to $3 million in new revenue just because of that thing I talked about, the state plan amendment that allows all kids. Their history, though, has been to focus on associates with supervision. In the short term, and I won't say the easy thing here. In the short term, I do not see them shifting because of the competition for licensed clinicians in the current mental health workforce. Kaiser, Northern California, has over 320 open licensed positions right now. They're paying 101 to 118. School social workers and public system social workers, counties, 78 to 105. And then community-based organizations, 55 to 85. So the folks that schools appear to be able to attract tend to be licensed eligible staff, MFTI, ASWs, and don't appear able in the current competitive landscape of licensed clinicians. And part of this is the commercial plans are all fighting it out on the federal parity laws. they're all having to hire up and staff up. So in the short term, I don't see a fundamental shift in that challenge. I wish I had something nicer to say.
All right, thank you. How do we include our efforts to train and engage parents as key decision makers at the program and policy level as medical necessity? We know that self-efficacy is key to wellness and mental health. I work in a CBH.
Yes. So whoever works for Alameda County Behavioral Health, thank you so much. And best wishes to all the beloved people I worked with for so many years there. I learned so much from so many amazing people in that system. Just to go directly at this one, mental health plans have a clause in the 1915B waiver called OQP. It stands for Other Qualified Providers. It allows mental health plans to determine their own provider classes. So Alameda County has allowed parent partners to be billable, meaning their costs, half of their costs can be covered and submitted through the behavioral health cost report. The challenge in Alameda County, and I'm not talking smack about any of my beloved friends and allies who work there, has been that these authorities exist, but the system has not prioritized the expansion of parent partners across the entire network of care. There are 6 to 8 parent partners in the early childhood mental health system, meaning every provider of 0 to 5 or little kid mental health has a parent partner associated with the treatment team. There should be a parent partner in every single foster care team. There should be a parent partner in every single adolescent treatment team, in every full service partnership. So unfortunately, the answer to that, to all my beloved friends in Alameda County, is you have the authority. You have to prioritize it. It's a system level decision.
Thank you, Alex. We only have about 2 minutes left today, and I'm wondering if there is anything else that you would like to say, share with our audience before we wrap up.
When I'm healthy, my internal narrative goes like this: everyone is doing the best they can with what they got. And I believe that that's true of us as a culture and society. That there may be bad people. I haven't met very many. And that if we can summon the generosity of spirit to treat ourselves and everyone else the way we treat our best friend's kid, then there might be a path forward here. It's really, really hard, I think, to see the amount, to be confronted with the level of suffering that we're seeing among children and not go to despair and attack. But I do feel like we're in a moment right now where there is change possible. Money is flowing. We just have to have the courage and will to say racism all the time, to shift away from pathologizing medical model intervention to building relationship and among and between us. And if we can see Medicaid and mental health more broadly as a social justice endeavor and not as a healthcare system play, I think the truth will be in the unfolding. Thank you.
Thank you, Alex, for leaving us with that wisdom. Thank you again so much for being here today to share with our attendees. And this will also be accessible on our website as well for those who cannot attend live. And thank you. That's, I really do appreciate your wisdom, and it is so important. And thank you for all of the work that you have done for our youth in California as well. And with that, folks, thank you all so very much for attending, and we look forward to seeing you at our next webinar. And I wish you all the very best. Be well.